to today's topic, the 2014-16 West African Ebola crisis, 2020 hindsight. Well, with all the focus, understandably, at the moment on coronavirus, it's easy to overlook that not that long ago, the focus of the World Health community was fixated on the outbreak of the Ebola crisis in West Africa. Indeed, that was the first time that the World Health Organization had declared a public health emergency of international concern, and also the first time that the UN Security Council had devoted a meeting to a health issue. Back then, the main vectors for transmission were unprotected handling of the deceased, largely due to local funeral practices, and that was having a devastating impact on frontline health workers. To tell us how that played out and to have a look at the Ebola crisis through the lens of what we know so far about COVID-19, we're joined by Professor Stephen Cordner. Professor Cordner is an internationally recognized expert in forensic medicine, particularly in the fields of mass casualty management and disaster victim identification. That's the reason that he was asked by the International Committee of the Red Cross to go to Liberia during the Ebola crisis to advise on reduction of transmission and infection control. His expertise has also been called on by the World Health Organization in the Philippines in 2013 following Typhoon Haiyan, and he was also deployed to Nepal after the devastating earthquakes there in 2015. At the end of last year, he was made a Fellow of the Australian Institute of International Affairs in recognition of his distinguished contribution to mass casualty management, disaster victim identification, and more generally, the development of international forensic medical capacity. Now, normally for a Fellow's address, we'd be making a formal presentation of the award, a large glass statue, such. Now, obviously, at the moment, we can't do that, but Stephen, we're delighted to have you as a Fellow of the Institute. We'll make amends as soon as we can with the award. But in the meantime, thank you so much for joining us, and I'll pass across to you for your talk. Thanks.
Well, look, thank you very much for that, Alistair. And it's wonderful to feel all of the audience, even if it's only virtually. But thank you so much for giving up your time to come and listen. I'd like to thank the Institute also, Alistair, for the entirely unexpected honour, I must say, of the fellowship. But as a result of that, I really do feel that I have to honour my mentor, Professor Keith Mann, who I believe introduced me to my fascination of international aspects of forensic pathology. And I am, in the 1980s, it was my very good fortune to be working in the Department of Forensic Medicine at Guy's Hospital in London. The head of the department was Professor Keith Mann, and as a captain in the British Army, he was present at the liberation of Bergen-Belsen on April the 15th, 1945, just 4 weeks ago and 75 years. There were 67,000 internees, 3,000 emaciated corpses lying around the camp. There was no running water, let alone electricity. Those living had either or one or more of typhus, tuberculosis, gastrointestinal infections, erysipelas, scurvy, and all, of course, were starving. Despite all efforts, 26,000 died in the following 2 weeks. Lest we forget. After the war, he became the British Army pathologist and was involved in collecting evidence presented at the Nuremberg trial of the doctors. He didn't speak much about any of that, but it was the background of a man whose Department of Forensic Medicine led to him having a greater influence, I believe, than any other forensic pathologist of his generation because of the continuous steady flow of forensic trainees from all over the world, spending 1, 2, or in my case, 6.5 years in his department. I show this photo because it's from 1982, and just to show from Keith's right there, Fayed Bakir, who became the head forensic pathologist in Iraq and who I saw in Baghdad in 2003, and that's a story for another time. On Keith's immediate right, Dr. Abbas Koronfeld from Egypt, and on Keith's left, Chris Lefkidis from Greece, and yours truly on the right of the photo. But that was just one group in 1 year. What I'd like to do today, Alistair, is give you a thumbnail sketch of the 2014 West African Ebola epidemic, but from my perspective as a forensic pathologist. There are some comparisons and contrasts that I'd like to make with the present COVID pandemic listed there, but I would like to stress that I am not a virologist, I'm not an epidemiologist, I'm not an infectious diseases clinician, but a talk like this clearly crosses a number of domains, and I'm just doing the best I can. Until 2014, outbreaks of Ebola had been confined to equatorial Africa. The first outbreak being in northern Zaire, and I'll mention that in a minute, as it then was in 1976. 2014, the outbreaks occurred in really quite a different domain of Africa over here in the West. The 3 countries involved in West Africa: Liberia, Sierra Leone, and Guinea. It really is very difficult for us to appreciate or to comprehend how difficult things are in a country like Liberia. The poverty, the absence of any recognisable, really, health system, tiny numbers of hospitals, 150 doctors for the whole population of 4 million. A third of the population have malaria. The youth of the population and the widespread nature of the population. You can see that much fewer people live in the cities, and those that do live in very close quarters. The extraordinary fertility rate of women. The bats are thought to be the reservoir host for Ebola virus. Bats can infect humans directly, so that a wandering hunter might come across a tree with bats and have a little sore on his foot and step in bat urine or bat feces. The wandering hunter could collect a bat that is infected or that is that carries the host, that carries the virus, and might butcher the bat for eating. During that process, blood, feces might enter an open wound or small sore on the person, or somehow infect a mucous membrane, such as mouth or eyes. The bat, so that is a way that a human being could directly become infected with Ebola virus. Another way, and perhaps more common, is that the bat infects other animals, chimpanzees, monkeys, antelopes. Those animals become ill and die, And if the hunter comes across them freshly dead, the hunter might think that that is good to eat. The butchering process might infect that person, or the undercooked meat might infect either the hunter eating the meat or anyone else who buys bushmeat on the by the side of the road. Once the virus has entered the human population, within 2 to 21 days, the person will become ill, and at that point, the person is infectious for other individuals. Particularly in West Africa, there is a strong compassionate tendency for families to care for their other family members. But in the case of Ebola virus illness, feces, saliva will have to be cleaned up. That will get onto sheets, will get onto beds, will get onto clothing, will inevitably get onto the hands of carers, and at that point might enter open injuries, open sores, or mucous membranes of the carer. If the patient dies, funerary practices in West Africa honour the body to a high degree. There is washing of the body, as you can see in the drawing there, not only by close family members, but also by friends. The body will often stay in the house, such as it is, already a small room, 4 to 6 people, 8 people maybe living in what we would consider to be a single bedroom, and the dead body will be in there at the same time. There will often be no running water, and so it is very easy to see how the disease can transmit in those circumstances. The illness itself commences, as with any viral illness, with lassitude and weakness and fever, sore throats, muscle aches, and then develops into more severe illness with diarrhea, vomiting, a serious gastrointestinal illness, multi-organ failure, liver failure, kidney failure. Then in about 1/5 of cases, a bleeding disorder is the final common pathway, with bleeding from all body orifices. It is a very unpleasant illness. Really, the only management is intensive support, such as you really need an intensive care unit for hydration and electrolyte maintenance and circulatory support to help the organs, such as kidneys in particular, but other organs, weather the storm of the illness. It is a very fortunate fact in the control of the illness that the patient does not become infective until they develop symptoms and signs. The first outbreak, first known outbreak, because there have definitely been previous outbreaks that were not recognised. Social scientists have found records of probable outbreaks in existing social history records. But the first known outbreak was in 1976. And about 4 days after returning from a trip during which he had bushmeat, probably from a monkey and an antelope, a teacher from Yambuku attended the hospital with fever and chills, and he was treated with injections. This mission hospital, which had 120 beds, so it's a sizable mission hospital, had only 5 multi-use glass syringes and metal needles. and these were multi-use syringes and needles, and they were often used without rinsing between uses. So he was treated for malaria, and he returned a week later with worse disease and died another week after that of a hemorrhagic syndrome of unknown cause. So all the while, that's over a 2-week period, he's had injections, multiple injections, particularly for the last week of his illness, with a syringe and needles that don't always get washed. So other patients have been attending the hospital and given injections, including from the same syringe and needle used for the teacher. Of course, during the early days of the illness, even because he was ill a bit at home before he came to the hospital, he was attended to by his family, and in his last days by staff at the hospital. Neither his family nor the staff clearly had any knowledge of the sort of disease he had, and these people developed similar illnesses and died. By mid-September, more than 120 patients had the illness and or had died. And over half those patients had directly acquired the illness from injections. And understandably, patients literally began fleeing the hospital. During the course of the outbreak, 13 of the 17 hospital staff were infected and 11 died. By the middle of October, so we're talking really 6 weeks, not much more than 6 weeks following the outbreak, the beginning of the outbreak, this new virus, a new genus, so your family, genus, species, this new genus of the filovirus family, Ebola, had been identified at the Centers for Disease Control in Atlanta with assistance from the Pasteur Institute in Paris. This specific species we're talking about was called Ebola Zaire, after, of course, the country. Ebola was a river nearby. There was obvious reluctance to call it Yambuku Zaire, because that would forever condemn the inhabitants of that town to stigmatisation. At the same time, and this speaks so highly of the team that responded to this outbreak, they had got the community on side about the need for isolating the patients and the need for rapid burial, both of which would have been running very counter to local practice. So huge achievement, and the overall quality of the response was such that this outbreak of a new disease, of a new virus, was halted within 11 weeks with 280 deaths among 318 cases. The basic clinical and epidemiological features of this new illness were defined and the virus was identified. I mean, just a stunning achievement. Moving along to the West African epidemic, the outbreak started in 2013 when an 18-month-old boy in Guinea became ill with fever. He developed black stools, which indicates intestinal bleeding and vomiting, and he died 2 days later. The village had about 31 houses and was in a forest region. And in retrospect, it's been said, but this is loose, that near to the boy's house was a hollow tree infested with bats. By the second week of January 2014, several members of the boy's immediate family developed a similar illness and rapidly died. And by weeks 3 and 4 of January, members of the extended family who had cared for the immediate relatives and been to funerals also became sick and died. So by the end of January, there were patients ill in 4 sub-districts in Guinea. Public health officials didn't become involved until the 24th of January and concluded that they were dealing with an outbreak of cholera. Now, there are very many diseases that, and it's very difficult to be critical of that. There are so many diseases that can be easily mixed with Ebola, and almost certainly these doctors may not even been aware of Ebola. But cholera, typhoid, yellow fever, bacterial septicemia, Lassa fever, malaria, the common, very common locally endemic disease, malaria, easily confused and wrapped up with Ebola virus disease. All of these are nasty illnesses. And this original misidentification of the illness was confirmed by a larger team with Western inclusion on the 27th of January. So it wasn't until the 13th of March, which is 2.5 months after the index case, that the Guinea Ministry of Health issued its first alert to the existence of an unidentified disease. And at that point, samples were sent overseas, and about 9 days later, the Pasteur Institute in Lyon identified Ebola Zaire in the samples. The very next day, that is on the WHO website with 49 cases and 29 deaths. By then, it is clear in retrospect that there were scattered cases in Sierra Leone and Liberia as well, although they hadn't been detected, investigated, or reported. And I think that I'll just show you that picture briefly to illustrate that what has happened with that delay is that it is given the opportunity for the disease to really, it is going to be very difficult to contain this disease because of the delay in getting to grips with it. And by then, people have moved around, come and gone from funerals back home without knowing what they have been coming into contact with. So during the course of this outbreak, that's a very brief summary of where the cases were and the number of them and deaths. You can see the high but variable fatality rate, which would have a lot to do with the availability of medical treatment, the early attendance by patients for medical treatment if it was available, and there are lots of variations in the willingness of people to attend for medical treatment, and there was certainly, particularly in the first 6 to 9 months, lots of variability in the actual availability of medical attention. The local public health systems were totally overwhelmed, and a truism in epidemics such as this is that the system becomes overwhelmed and everything comes to be treated as though it's Ebola, and the background illnesses get neglected. You can see there one thing I'm going to mention a bit later, the significance of the toll on healthcare workers. This outbreak, you can see, is several times more than the combined toll of all previous Ebola outbreaks. At this point, I owe you, the audience, and you, Alistair, an apology, because in the blurb I provided for this talk, it was not the case that this was the first public health emergency of international concern issued by the World Health Organization. So that's a gremlin that got into my blurb, for which I apologise. It was, in fact, the third. The first was the influenza pandemic of 2009, and the second was a wild polio outbreak involving Pakistan, Afghanistan, and Nigeria earlier in 2014. Nonetheless, that's an important date that we will come back to towards the end of this talk. A few weeks after that, the United Nations Security Council, the first ever meeting on a health issue, and declared it to be a threat to international peace and security. And then the day after, over 100 countries jointly sponsored a motion in the UN General Assembly, which was unanimously adopted by all 193 members, about the response to the Ebola crisis. By early October, the epidemic was continuing to outstrip the international response. There are a number of factors which affected the spread of this illness. Mistrust of government. All those three countries were recovering from what were regarded as some of the most ferocious wars on the African continent ever in the 20 years up to 2005, involving people like Samuel Doe and Charles Taylor, the latter subsequently indicted in a UN criminal tribunal. There was denial, which that sign is partly addressing. So, and some people believed that the disease was, for example, a concoction from corrupt government officials who were simply seeking donor aid dollars. That was the type of sort of way of thinking, this isn't real, it's just another example of corruption. Not so apparent in that photos, but you'll see a bit later, the dense slum-like city living with large numbers of people living in tiny spaces, often without running water, a non-existent public health system. Not a single laboratory in any of these three countries could test for Ebola. There was no history in any of these countries of a public health system which could trace contacts. The healthcare workers were not trained in the proper use of non-existent at the beginning personal protective equipment. There were no body bags. It is very difficult to imagine a scenario which was more suited to the unchecked spread of this disease for several months. And funerary practices. So, as I've mentioned, many people were staying at home. They didn't want to go to a hospital. The new treatment centres that were springing up were surrounded by barbed wire and had people in moon suits walking around them. And people, if you went to one of these, you were unlikely to ever come out. So there was enormous psychological disincentive for going to such a place if you were ill. So many people stayed at home, had their illness at home, were cared for by families, and of course propagated the disease. So by the time I arrived in late August, body collection teams organised by the International Federation of Red Cross and Red Crescent Societies, but actually personed, they were almost all men, not completely, but almost all men, and these were members of the local Liberian Red Cross who were being paid $15 a day, $15 US a day, but they were all volunteers. One is man who I got to know a little bit. He was an IT technician who simply said, you know, I just had to hear the call of my country to come and help. So this is the team donning their PPE. As I mentioned, I'm not an infectious diseases person, but to my eye, they were expert at putting on their PPE in the best possible way. It was all supervised by this nurse here who was part of the team and making sure that they both put on and took off their PPE correctly. And to very quickly follow the team through the collection of a couple of deceased. You will not see any deceased in these photos, so don't worry about that. But here we are going into a one-room dwelling, led on this occasion by the sprayer, hypochlorite solution. You can see there the entrance to this one-room abode, the deceased covered on the floor. You can see in the mirror the sprayer's already in there, spraying around the deceased. There's the deceased. You can see some blood-stained material there, which would be from fluids issuing from the mouth and nose post-mortem. I would think that this is, generally speaking, a better class of abode to what the team would normally be always used to. They're taking in a body bag, putting the body bag next to the deceased in this very cramped space, and placing the deceased in two body bags, actually one inside the other, and moving out. The sprayer, who is also a supervisor of the team, has got eyes like a hawk for the slightest evidence of any contamination, and you can see on the boot there the possibility that that member of the team has collected a little bit of that blood-stained material on his boot, and that is being attended to. And then they make their way back to the vehicle, put the deceased on the back of the vehicle, and move along to the next body. The teams, there were about 3 teams. There was a well-publicised telephone number to activate a team if you needed a body collected. These houses are organised into small units, if you like, so that there was wouldn't be left to the family to ring that number. There might be others in the community who would do this. This is the collection of a second body, another unusual location, but a dwelling on a beach, and the deceased, you can see there lying in the shade of the wall. The team had to come through a village to get to this point, and had to make their way through angry villagers who are confronted with the reality of this when they see people dressed like that coming to collect a dead body. And a totally understandable reaction is, you know, well, you're confronting with this shocking thing that we don't want to know about. And they got angry and they were shouting. So in fact, they decided they would, really it was a risk, I think, to put the body over the fence where the car had been able to find its way there. So back into the vehicle and on to other places. By the time there's about 5 or 6 or 8 bodies in the back, through the traffic, you can see the car there driving on the wrong side of the double lines, oblivious of traffic. When we got caught in the traffic, police would hop out of the third vehicle and start beating with batons cars. It was very unpleasant, frankly, to be in such a procession. And the bodies were taken to the crematorium. There were, by presidential decree, all bodies were to be cremated. There was one cremation per day involving about 50 bodies. And the smoke you can see rising at the back of the photo is the ashes of the previous day's cremation. I'm now going to briefly touch on some particular areas of interest in this Ebola epidemic and mention COVID along the way. At the same time, you'll see quotes from Daniel Defoe's A Journal of the Plague Year, referring to the 1665 bubonic plague in London. I'm grateful to my daughter Anna for access to this. The collection teams were paid volunteers, and a remarkable job they did. About 60 to 80% of cases in Guinea and Sierra Leone were traced to funerary practices. And this effectively means bodies at home and before a real handle was got on the disease. Cremation had been mandated in Liberia because there was really no organised disposal of bodies in ordinary circumstances. There were very few cemeteries that actually cost money to use. So families in normal circumstances would take their dead family member and bury them out in the bush. So that was clearly unacceptable in the circumstances, and the best way to centralise it was to have organised cremations. There were no reported cases of transmission to trained body collection teams, a real tribute to their training by the Médecins Sans Frontières, heroes of this epidemic. As far as we know, there are no cases of post-mortem transmission in the COVID pandemic, but one interesting and I think sort of a symbol of what happens in many domains in situations such as pandemics. Just look at this regulation from Sri Lanka, 61A subsection 1. A person who has died or is suspected to have died of coronavirus disease shall be cremated. Subsection 2, no person shall hand over the corpse of a person who has died or is suspected to have died of coronavirus to anyone except someone who undertakes the necessary duties of cremation. Of course, this is very upsetting for a significant proportion of the Sri Lankan population, Muslims. I think most of us would say that this is unnecessary. The Sri Lankan would say, well, it's early days of the virus, we don't know, we can't be sure. We can't be sure that there's sufficient infrastructure for people handling bodies to keep out of harm's way, so we think they should be cremated. I think the response to that would be, well, it takes just as much effort to get a body into a crematorium as it does into a grave, and there's absolutely no reason why with the same sort of care the body can't be buried, and that is indeed the advice of the WHO and the ICRC. The numbers are I think the numbers, as you can see at the bottom, and I think it's well accepted that those numbers are potentially quite understated. for the reasons I mentioned in relation to people staying at home, many of those deaths would have been from Ebola virus disease and would not have been recognised. There is no death certification system in these countries. Unbelievably to me, 65% of the world dies in countries where there is inadequate death certification. And by inadequate, I mean it does not enable local public health authorities to make decisions based on some knowledge of why the population is dying. But in ordinary life in West Africa, there was effectively no functioning death certification system. Another reason why those deaths at home would have been missed. It wasn't until September, October, when CDC got seriously involved with the management of this outbreak, that some post-mortem testing was introduced into the system. In relation to COVID, we saw recently in Victoria that 30 extra cases were discovered by massive testing. And I think that sort of shows that the numbers for this COVID outbreak in a country like Australia, obviously more reliable, particularly because of the availability of testing. In the United States, for example, the availability of testing until now, I think, has been affected by issues of costs. So there would be lots of people not having testing and people being concerned about the consequences of isolation if they should test positive. And of course, you've got to confront the realities of having the illness if you go and have a test. So there may be quite a few reasons why people, particularly in the US, are not having tests. But I think what is really interesting is that this issue of testing may be part of the story, a story which is, I can't give answers to at the moment, and I haven't been able to find out answers for what appear to be the relatively low numbers of COVID positive cases in South Asia and Africa, for example, at the moment. Healthcare workers, the healthcare workers in Ebola are a completely unrecognised sacrifice in the service of humanity, as far as I'm concerned. Look at that. In Liberia, 8% of the healthcare workforce died during the Ebola crisis. Insufficiently recognised consequence. And of course, it's in the background, it must be, of every healthcare worker who attends to their job today. Although from what I can see, for example, in the UK, I've seen information that suggests that healthcare workers have not got a higher fatality rate than the general population. Interestingly, social care workers had twice the rate of death than the general population. Yesterday was International Nurses Day. Vulnerable populations, I'd just like to very briefly mention prisons. We've got no idea what prisons are like in large parts of the world. In Liberia, the authorities and the Red Cross were absolutely beside themselves with worry about what would happen if Ebola got into the single, quite large prison in Monrovia. And I've got no doubt what would have happened. They would have broken out there's nothing that would have stopped them. I'm not sure how they would have done it, but they would have succeeded, and that would have been just unbelievable. Fortunately, that did not happen, and I think we're only just starting to hear now what is happening in some prisons around the world. We may not hear what happens in lots of prisons. We may not hear what happens in lots of populations who are out of sight and out of mind with the world in lockdown. But interestingly, you would think you would see some photos perhaps of what was going on in slum areas of South Asia, which we haven't seen yet, of large numbers of deaths. Now, whether that means something different is going on in that part of the world, or whether it's just early days, for me, is an open question. But if there's anyone in the audience that feels they've got a handle on that, I'd be really grateful to hear from them. I did read recently that there have been, as of May the 12th, 340 deaths in US prisons, according to Intercept, an online news source. And all around the world, there have been calls to reduce prison populations. As far as I can see, that hasn't been heeded to any great extent so far. Many people might have been aware that in India, when the lockdown was announced, huge numbers of people were forced to try and get back to their homes, either in India or in other countries even. And this just shows masses of people trying to get on small numbers of buses. And many of them ended up having to walk, sometimes hundreds of kilometres home. But this is locked down in the slums of Mumbai, and so quite why the numbers are as low as they are is a little mystery to me. I'll just very briefly, I've got about another 2 or 3 minutes, Alistair, and then I'll finish. This is some very brief, it's very difficult to get comprehensive information about the costs of the West African Ebola virus outbreaks. There's some grabs, but I just draw your attention to when the attention turned to Ebola virus, it came off these other illnesses. And in part because people with those illnesses would have kept away from hospitals. They didn't want to run the risk of getting Ebola virus, but in part because the health system simply couldn't cope. So all of those other people are added to the death toll of the outbreak. Interesting, this 30% decrease in vaccinations, that probably for much the same reason, not so much because of distrust of vaccination itself. And finally, just very briefly, and it runs the risk of doing a disservice to this issue to do it very briefly, but following the SARS epidemic in 2001 or 2, a new system for declaring global health emergencies was developed. And that involved the declaration by the Director General of the WHO of a public health emergency of international concern. And you can see the definition there. Please note that the spread of disease does not necessarily mean infectious disease. So it could be a chemical outbreak or a nuclear outbreak. And that is why in this formulation, you don't see the word epidemic or pandemic. Declaring a public health emergency of international concern is the relevant thing that WHO does to alert the globe that there is a really serious problem. So, and this is my last slide, Alistair, just to show you what happened in 3 declared public health emergencies of international concern. You can see there the time between the beginning of the outbreak, when it was detected, and when it was declared a public health emergency. I wasn't going to put dates in for COVID, and no doubt that people will be arguing about that. But I suspect that the number of days to a declaration of public health emergency of international concern will be relatively modest compared to certainly Zika and Ebola. One thing that WHO has laboured under is some criticism associated with the declaration of the influenza pandemic in 2009, because nobody felt that it was terribly serious. But it was a novel influenza virus that had killed millions of the kind that had killed millions in 1918, and you'd be again Director General of the WHO if you didn't declare a pandemic with a new version of it in 2009. A lot of people completely overestimate the scale and size of WHO. It has a budget of a bit over $4 billion, which wouldn't be much more than the budget of the Melbourne Hospital and Alfred Hospital put together, maybe a third major public hospital. But so it is a tiny organisation, really, charged with a huge responsibility. And to finish, Alistair, criticism of the WHO for the time it took to declare a pandemic. The WHO does not declare a pandemic. As I've mentioned, the relevant thing is to declare the public health emergency. And the Director General has been criticised for delaying until the 11th March declaring a pandemic. He used the word pandemic to describe the situation on March the 11th, but in the same breath said it doesn't change what we're doing, doesn't change the assessment of what's going to happen, and it doesn't change what countries should be doing. So, look, thank you very much, Alistair, for that opportunity, and I know that I've probably gone a bit over time, so that will truncate the involvement of the audience. I apologise for that.
That's quite all right, Stephen. To listen to an international expert is what we're largely here for. So, but we will try and get through some questions in the next sort of 8 to 10 minutes. And there'll be some you've answered already in terms of the WHO in particular, but there was one question which comes a little bit back to the Ebola and the areas you were talking about that were affected by that particular outbreak. Is what steps have those local governments taken to minimise frequency or recurrence of another Ebola crisis? You know, are there, for example, labs now locally available that could test for it?
Yes, well, as a consequence of the response to the Ebola virus, something like 20,000 people have now, or some huge number of people have been taught how to use PPE and how to care for patients. So there are now 20 laboratories, I think, in West Africa which can now test for Ebola. There is now a whole cadre of people who can trace contacts of infectious disease and deal with them. It's going to be really interesting, Alistair, to see how these countries fare with COVID, for example. I think they have been left with improved public health surveillance. Won't be like ours, but and I've got no doubt that they will probably do, quite well because of this experience. They'll do quite well today.
That absolutely picks up one of the issues, that the obvious stated concern that the COVID will now run away in Africa. I get two questions covered. That bats are seeming to get the blame both for Ebola and COVID as vectors. And I suppose to the same extent that the wet markets in China have been seen as a source, is there a similar focus on the bushmeat markets, if there's such a thing, over in the Ebola area?
Well, that's a good question. I'm not sure that I can answer that. That is really addressing a cultural issue. I suspect it is still quite, happens all the time. Bushmeat is definitely still available on the roadside. Perhaps more people are aware of the significance of the possible adverse outcomes from buying bushmeat. But I can't sort of give you factual answers to that. It is going to be interesting to see what happens to the markets in Asia.
There's one question I want to make sure we get to, because I think your chosen career path is obviously not for everybody, and I think viewing some of those pictures would explain why, but we're very grateful that such as you will go and be involved in that sort of environment to keep us all safe. But you've obviously inspired a senior high school student who's watching, because he is saying, what course of study would you suggest to follow on to be a frontline public health professional as you have been?
Well, I wouldn't say I wouldn't really say I've been a frontline public health. It's a little bit public health what we do, and public health is in our mind every day. But if the student means frontline public health in West Africa, you could pursue a course to become a doctor and go down that path and become an epidemiologist or international public health person. You could become an academic, you could become an actual hands-on person working for numerous international agencies and Médecins Sans Frontières. I can't speak highly enough about, but you can become nurse, you can do the same thing, become a scientist, you can do the same thing. So it's a great, I'm so glad that question was asked, and it is a life of, it's an adventurous life.
It certainly looks it. Again, I mean, I'm possibly pitching questions that are not necessarily in your sphere of expertise, but there's clearly interest. But vaccinations, what was there, or could there have been a vaccination for Ebola? And do you see one being developed for COVID?
Well, that's the second question's outside my, definitely outside my pay grade. And the first question is, by the end of the outbreak, there was a vaccine that was trialled in Guinea and was shown to have really quite high efficacy. It has been a very interesting aspect of the response to the 2018 and ongoing Ebola outbreak in the DRC, the Democratic Republic of Congo, which is happening now, complicated by the existence of violence and civil war. And there were 300 doses of that vaccine available, and the distribution, how to distribute those vaccines and their efficacy in the Congo is a matter of ongoing work and development. But it, as far as I'm aware, is a vaccine that is regarded as still being under development and hasn't actually been licensed.
We've got possibly time for a couple more questions. There's one which is, I guess, on a geopolitical perspective. Considering the international response to Ebola back then, including the Security Council declaration you outlined, to what extent do you think the greater impact that COVID has had is that the nature of the virus, or is it the lack of leadership or slow reaction to a new disease?
Well, look, that's a huge question, and of course it is variable in different countries at different times. But I do think it's pretty clear that leadership is an important part of a response. You need to have the trust of the public. If the public decide they don't want something, they're going to go and do what they like. So it is good leadership that gets as many of the public as possible to follow the right course. I can't do any better than that at such short notice with such a huge question. I'm sorry.
Absolutely. Well, maybe we've got a final one, just quickly, I suppose, from you. Is just, are there any measures that you'd like to see implemented globally to strengthen public health systems?
Well, the states, as part of their undertakings to the WHO at different times, have undertaken to help the development of public health surveillance, and it hasn't happened sufficiently well. So surveillance, capacity locally to keep an eye on the disease burden and the range of diseases that are happening, not responding and reacting, but being on top of it and being able and being there as the new disease happens. That requires investment in surveillance and investment in public health. And I think we can say that the cost of reaction is huge and the cost of prevention is minuscule compared to the trillions that are now being wheeled out to respond to this.
Well, Stephen, thank you very much. I think it unfortunately brings us more or less to the end of our allotted time, and we always try and stick pretty much to our published schedule. So even though there are some questions still waiting, I think you've covered many of them. You've shared widely in your expertise, for which thank you very much, and thank you just for your contribution to your whole field of expertise and coming on as a fellow of the Institute. It's very much appreciated. For everyone watching online, thank you too for your interest. We hope you've enjoyed it. We'll send out the recording and the slides so you can catch up. So at that stage, I think I just thank you once again, Stephen, very much. And maybe if we can close the share screen, we'll just from our end. But